I think that the idea that quality improvement is like a toaster that we buy and we plug it in and now we have a toaster, that's wrong. It's the continuing and lifelong commitment to learning about learning.
My first question to you is, in what ways do you see quality improvement having changed over the years, and how is that change reflected in our ability now to work at different levels of the system, especially the level of population health and system-wide improvement?
When we say quality improvement, what I take that to refer to is a collection of continually evolving sciences that help us together in complex systems do better at whatever we want to achieve. And in that sense, the evolution of those sciences since the 1980s, even before that. So I think we've learned a ton how to apply these sciences in healthcare, better uses of data, really thinking systemically. I'm really excited by Public Health Ontario's embrace of this to take this to the next level of public health. That wouldn't have happened 30 years ago. That's a newer perception. Particular changes have been, number one, I think, much deeper understanding of the importance of the voice of the patient and the community and the shift of power. Paul Batalden's leadership in the world of co-production, or just thinking about the people we try to help as actually co-inventors of the healthcare systems that we need and full of knowledge about improvement. The linkage to social determinants of health, the origins of quality improvement in healthcare were working largely in hospitals and largely in acute care processes, ventilator pneumonias, hospital-acquired infections, safe surgery, and so on, all extremely important. But it's only in more recent times that we've tried to draw the line over to what we actually know causes health, which Public Health Ontario is now becoming a leader in. I think the third theme is equity. In each of our countries, we've had problems of excluded minorities, people at disadvantage, and now I sense in most of the quality improvement movement real strong inquiry as to how we can move toward social justice and equity. Those are some of the changes, and it'll never stop. It'll never stop. I think that the idea that quality improvement is like a toaster that we buy and we plug it in and now we have a toaster, that's wrong. It's the continuing and lifelong commitment to learning about learning.
One of the things I've really appreciated is the scale at which IHI is working, because in the early days, working with individual teams and hospitals and small systems, and now working with large-scale systems, large-scale change. The 100,000 Lives campaign was kind of a real shift in focus, I think, and that was 2004, I believe, that was launched. And then the 100 Million Lives campaign, reaching out to improve health around the globe, really. And I wonder if you'd talk a little bit about the scale issue and how you worked at scale on those issues, because it seems really daunting, but the achievements have been remarkable.
Yeah, much more to do than we've done, but it's pretty thrilling to watch. I think scale has two meanings here. One is given an improvement, let's take infection control or improved engagement of patients in decision-making, all improvements. The first issue of scale is, if it works here, how can we bring it everywhere? So it's the sort of like the replication of an effective process in many, many places throughout the globe. We've seen that work really well in areas like infection control. Another kind of scaling is to the size of the system we're working on, which is highly relevant to Public Health Ontario. Yes, we can go to a small office practice and help a particular individual clinician shorten waiting times or increase reliability for evidence-based practice at the clinic level or the office level. But what about a nation? Could a nation improve its health and well-being continually all the time? Answer: yes, but you have to deal with infrastructures and systems much larger than we'd ever address if we were just trying to prevent a few infections.
What's your thought about how to be more effective in executing these grander schemes to bring people into this scheme, to make them part of the work moving forward, and to build on successes so that we have something larger in the 5, 10, 15 years that it takes to make these kinds of changes?
There has to be glue. Something has to hold us together through thick and thin, because there are stumbling blocks and there are problems to staying together. Overall, I mean, I fear to say this because it's such a kind of vague concept, but it's leadership. It's having at the highest levels of leadership, organizationally and nationally, or provincially, in your case, maybe constancy of message, a sense we're going to get this job done. I see it. There's a story in Singapore. Singapore has been water dependent on Malaysia for a long, long time, and decided to become water independent, which is a really, really big deal there. Very, very hard to do. And they did it, but it took them I think about 15 years. But the government, all the leadership were focused on the water independence of Singapore, and they accomplished it with that sense of constancy, but it came from the top.
I learned something from Paul Batalden many years ago, and he's influenced a lot of my thinking, and that is, don't wait for everybody to get on board. Work with the people who will work with you. Show that you can do something, and then others will follow. And I'm just wondering if that makes sense for the work you've done.
Absolutely. So I mean, like you, I absolutely worship Paul and his wisdom and his able to bring lessons. We saw it become real in the 100,000 Lives campaign. For those who aren't aware, it's the campaign in 2004 that you mentioned. What had happened was that IHI, through its contacts really around the world, and the work of some of our faculty, like Carol Harridan in particular, had recognized about a half dozen pretty simple process changes in hospitals that seemed demonstrably related to reduction of avoidable deaths. So we had a kind of retreat, and our board said, well, could we bring this everywhere, these changes? And that was the birth of the 100,000 Lives campaign under the brilliant leadership of my colleague Joe McCannon. But remember, this is 2004. IHI had no power. We didn't have money. We didn't have we couldn't force anybody to do anything. All we had was what Paul Batalden called abundance of knowledge, abundance of goodwill, and so by invitation, we went to the community of hospitals in the United States. By invitation, said, "Hey, everybody, would you like to save some lives? We calculate maybe 100,000 in 18 months if you make these changes. If you want to join in, welcome. Bring it. Bring what you have to offer, including other ideas." So we kind of found this way to open the door to what ended up being 3,300 hospitals. We didn't pay them a nickel. We had no power. They just joined. And that was the biggest lesson maybe in my career. I think of all the things I learned or observed was the power of embrace, the power of invitation, the power of welcome, the power of respect for what every single entity or individual can bring to the table. And that's the resource that'll save us if we're able to mobilize it. And you mentioned locality. So the way this works is even big ideas that have a strong center still need to be adapted locally.
Yeah, I totally agree. And I think, we live in a province that has now 16 million people, just turned to 16 million, but it's in a landmass that's as large as France and Spain combined, right? And it's very, very different if you're in downtown Toronto from the reality, the experience, and the resources needed to really work on population and public health in Northern Ontario and other rural, remote areas. And I think one of the challenges is making sure that we can create common goals, but then adapt activities locally to make sure that they're able to do something different. I'm just wondering, from your experience in many different environments, what you've seen as a useful way to help people to make those adaptations, to really say, yeah, I agree on the larger goal, but in order to do that in my environment, we're going to have to do the following.
Well, culturally, I guess the key is respect. We see Dr. Sanjeev Arora and his amazing ECHO project, which works around the world. He begins with respect, which is, although there's a lot of smart people at the medical center in Albuquerque, which is the hub, there's many more smart people out there in the tiny clinic or wherever they're working. And this idea that we have authentic respect for the knowledge that people can bring at the local level, number one. Number two is learning communities. I think you can get awfully isolated. And the idea that what has to happen in a rural community on Hudson's Bay is going to be different from Ottawa, absolutely yes. But many rural communities working together, saying, well, "Hey, how did you handle this? Have you ever run into this?" That can be very powerful. Our colleagues at Cincinnati Children's Hospital, Peter Margolis and others, have really been working hard on this network learning idea, which I think can be a tremendous accelerator, both to improvement, but also to the joy of improvement, because then you're part of something bigger than yourself. So I think that's really cool.
Thanks so much, Don. We really appreciate the opportunity to have this dialogue with you today, and we've learned a lot. But as you've said, we still have a lot left to do as we adapt these tools into the public health, population health space, and learn from the work of people in the field who are dealing with these constant pressures to try and improve population health in Ontario, this large, diverse province that we're in, luckily with strong leadership to move us forward. So thank you so much for being with us today.
My pleasure. And based on the track record in Ontario, you're the people that can do it. So go for it. Thanks.
Thank you.
Bye-bye now.
Bye.